Welcome to the first virtual Infoblender, and I would like to thank Paula for having organized this session. So we are going to talk about measuring icebergs and about the project on Coronasurveys that has been running for a little more than a month. We also have in the audience Antonio Fernandez, where everything started. So we are going to see that on the next slides. So my name, most people here already know me, but my name is Carlos Baquero. I'm from in university and in ESTEC, in ASLab. And me and many other persons from many different countries have been kind of collaborating to this project that is linked to the current epidemics. So I'm going to go to the next slide. So this is kind of the context. So we had, let me just reorganize here the windows. So the situation in March 13, it was little more than a month ago, but it looks ages now. So many things have happened since then. So in March, in the 13th of March, in particular in Spain, the outbreak was taking a lot of speed. I looked for some news in the newspapers from that day, and from El País we knew that Spain became the second country with the highest number of cases, and also some actual numbers. So there was a jump in the number of cases. So before, in the 12th, there was 3,000 cases, and it jumped 1,200 more into the next day in March 13, with the spread mostly in Madrid, the Basque Country, and La Rioja. So what can we see here is that under rapid growth, it's very hard for a country to keep up with conventional testing with swabs and PCR. And even when the testings are done, sometimes there is a big delay in reporting, and this was actually the case in Spain. So this is natural in a situation of crisis, and this led the leader of the project, Antonio Fernandez, that is also in the audience, to, let me just disconnect my video so that we have better quality. So I guess this came to the mind of Antonio, and you'll be able to talk to us later. What could be done? Will there be a simple thing that could be done that will allow to make a quick estimation on the number of cases? So precisely on March 13, Antonio made a question using the simple surveys that were available on Twitter. So he asked random people to kind of answer this question. How many people did they knew that had symptoms of the virus or were diagnosed with the virus? And people made different responses. This actually had a very good outcome in the number of responses. It was 722. Actually, I made a mistake here. I said the cases were, no, actually the number of responses, sorry, was correct, was 742. And people could say that they knew one person, 0, 2, or 3 or more persons. So what can we do after the survey is closed? What can be done with this kind of numbers? So what Antonio did with this was, from the percentage and knowing the number of people, he inferred how many people answered in each category, and then did the appropriate multiplications. And he came up with a number of reported cases of 374. Okay, so this is a kind of the number of reported cases from this sample of 732 people. But what he wanted to see was what is the proportion of persons that are infected at a given point in time in a given country. So to do that, he used a result called that came from anthropologic research. It's called the Dunbar number, and it kind of tracks how many persons a human being can keep close relationship with, and can kind of keep track of what will be their health status. So this is kind of a multiplier to the reach. So we had responses from 700 people, and we kind of estimate that they are covering the number of people that is multiplying these two numbers. So with that, we can do a very coarse calculation. That is, we see the ratio of infection that we are estimating, cases divided by reach. And then if we multiply this by the population in Spain, we get a number here. The number was 150,000, okay? And so this number is actually quite big. It's about 30 times more than the official number on that day. So there are possible explanations to this. One is that this technique has a level of error, and that is understandable. The other is also that there is a big gap between the cases that are officially diagnosed and the actual number of people with symptoms in a given day. And later we came to believe that this is probably close to the order of magnitude of the number of persons with symptoms that Spain was experiencing. So what can we say about this strategy of doing surveys? So this is clearly an unorthodox approach. So typical surveys, they do a proper panel selection. They select people based on the socioeconomic stratification, on age, on regions, and nothing of this can be done in this kind of open surveys. So this opens a lot margin for error, but maybe this margin can be compensated with numbers, with trying to get lots of responses. Another thing that is not possible is to track answers from the same user across time, okay? Because we are not even storing cookies, any kind of user identifiable information. So people might answer repeatedly, and we hope that they will do so honestly. But again, we are still, by not having a clearly defined panel, we are subject to fault injections. So people can introduce erroneous reports, and we are aware of that. We'll see later on what we can try to do to counter that. So on the positive points, we really don't ask and don't store any kind of personal data. So we don't query the health status of the persons that are answering, and we don't ask them. So this means that we don't have issues with the GDPR regulations, though since we are asking information to people and since we are making the answers themselves, anonymous answers, publicly available, we sought out, and this was done in INDEA by Antonio, we sought out ethics board approval from INDEA to be able to conduct a survey, and we collect the consent from the users before the answer. So another positive point is that we have at least the potential for a high number of answers and a big reach in the answers that we get. So things evolved. We aggregated collaboration from lots of other persons and institutions. So now this is where the site is located at coronasurveys.org. And we have kind of here we have access to the team members, and we say that the data is available, and we have kind of the logos from the several institutions. So looking more into detail into the survey, we ask two very simple questions. I put simple between commas because the first question itself is not so simple like that. So for any given country, after using informed consent, we ask, how many people do you know personally in this geographical area? And from our experience, this is one of the toughest questions for users to answer because people don't have a very good notion of how many people they know that they could be aware of their health status. Okay, so we give them a kind of a hint, 100. We didn't actually put a number, we put a similar number or a round number, 100. So this later on will have an effect that we get lots of answers with the default value. So we are pondering if we are going to remove this number or not. Then we ask the second and last question. So how many people do you know that have been diagnosed or have symptoms of the disease? And then people will answer. Hopefully most people will answer with 0, but some people will report knowing cases. We also did a localization of these into several languages. So I have here the example of Ukraine, and we will actually see some data from Ukraine because we got interesting data from that country. So we have localization in several languages. And we have open surveys, I believe, almost for all the countries, although only some countries do we get enough participation to get to be able to produce estimates. And this is one of the biggest challenges here, is to get enough people to know about the survey so that we can get enough responses. So once we got the data, we need to do a bit amount of data cleaning. So we can look at survey responses as pairs. So the pairs are cases that are reported by a given participant, and the reach, how many people they reported to know. So the way we do the cleaning, and we are evolving this, first we remove outliers by using two different techniques. So the first is that we look at the reach, and we look at what is the distribution of answers about that report on the reach, how many people people are reporting to know about in general. Okay, so we look at the distribution of that, and then we will detect outliers, and we use a standard definition for outliers. So we remove entries that are 1.5 more times. So we calculate interquartile range, we multiply by 1.5, and anything above the third quintile more than this, it's going to be considered an outlier. So this will remove people that think that they know too many people, that is not conceivable. We also look at each answer, the proportion of cases by reach. So this is kind of what is the proportion of people that they think have the disease, that they know have the disease. And we kind of remove entries that have more than a given value. We've chosen 0.3. So we might have people that genuinely know more than 30% of their acquaintances with the disease. But we don't really want to survey people that are in hospitals or are in gated communities. We want to survey more people in the general population. So those cases that are in very densely concentrated areas, we hope to get them reported to people that are not actually with all their contacts there. And this also removes some of the possible attacks to the survey. So we are improving the outlier detection to do a combined outlier detection. So this will be kind of constantly improved. So having cleaned the data, we can start looking at the estimators. So if we assume we have n response pairs, again, cases reach, and that we are querying a region of population P, we can produce three estimators. So the first, and it's the default one, it's a weighted estimator. So we sum the number of cases reported, we divide it by the sum of the reach, and this is kind of a weighted average that depends on how many people were reported. Again, this is after removing outliers, and then we multiply this by the population of the region. We also have an alternative that takes a balanced average on the ratios. This one does not provide a very different estimate from the standard one. So I will normally be focusing on the weighted one that is now the default, and also on the Dunbar one. So the Dunbar is going to only consider the number of reported cases. And since we found that people are very bad at determining how many people they know, we just, instead of summing the reach, we consider the number of responses times 150. And later I will show results from the weighted and the Dunbar estimate. So here we have some results from Portugal. So only when we get enough responses, we produce outputs on that given day, when we collect enough responses from the previous day and that day inclusive. So the line that we have in full is the number of official tested cases and reported by the health authorities. And the scale is logarithmic. And you see that we are always estimating above this number, okay? And we can also see that the Dunbar estimates are more conservative on the number of cases. And the default estimate, the blue one, reports a few more cases than the Dunbar, okay? So this is what we have for Portugal. For now, this is kind of, okay, so this is just what is the outcome of the survey. We have no calibration at the moment. We'll see what we can do about that. But at least you can see that we are reporting in a consistent way across different moments of survey, and it kind of follows the curve. Now, if we look at a country where we have more responses, Spain, we see the same pattern. Here, the separation is bigger from the official number of reported cases and what we are estimating. So this is probably an indicator that the situation in Spain was less under control than in Portugal, and it was more difficult to get proper testing in a timely manner underway in Spain, okay? So we need to discuss this and have a critical observation on this. So what we have several data points. These data points come from batches of 30 or more answers. And we see a consistent evolution across time, okay? So the batches are different, so there's not a lot of variation between the batches, and we see some evolution with time. Notice that we are estimating the cumulative number of cases, so we expect to see some grow-only evolution in time. But how can we know if this data is meaningful? Again, this is a very unorthodox way to do a survey, okay? So we need to be able to answer this. And in order to do that, what we did is we in absence of actual tests for all the population, that is not realistic. And in the future, we'll have serological surveys that are already starting, but we cannot apply them retrospectively to the moments where we did the surveys. So we need other independent estimates. So here we looked also at a paper from that was, actually, I think this was a news item in Nature. You have the reference over here. And I will try to just explain what is the gist, what is the general idea over here. So the idea is that if you assume a case fatality rate of around 1%, so case fatality rate is when all the data is collected and all the cases can evolve into a known outcome, you will be able to calculate this by dividing the number of deaths that were attributed to this disease by the number of cases that were detected and tested. Typically, this is a work in progress number because not all the cases have time to reach an outcome. But if you are in the growing phase, in the exponential phase of a pandemic, you can do a kind of a back of the envelope calculation. So since one death, in this case 1%, represents like an underlying 100 cases, and if cases are doubling on average each week, and if the time from onset of symptoms to outcome is around 2 weeks, this will vary, you bring it a coarse number of 400. So there is an estimate that just picks the reported mortality a given day and multiplies by 400 to kind of estimate what will be the likely number of cases now that we get from this number of mortality. So this is a very coarse-grained estimate that we still used it to see where we were placed. So we actually can do better than this. We can do a more fine-graded approach to the corrected case fatality rate. So what can we do? Again, we know that this comes from the ratio of fatalities divided by the detected cases with known outcomes. So in a given day, we know the fatalities that were reported, say, yesterday, and the cases that were reported up to yesterday. But we cannot simply divide this number of fatalities by the number of cases of yesterday, because very pragmatically, the cases that were detected yesterday, they did not have time to become either recovered or unfortunately to outcome into a fatality. So we need to look at a prior number of cases that will be smaller, that is the cases that have enough time to be able to already have resulted in a fatality or a recovery. So this is an established technique, and this finds the correctors or the adjusted case fatality rate. So with this, the first step will be to find a stable baseline for this. And so there is a paper that was published some weeks ago in the Lancet. And this paper does several adjustments from UN data, and it estimates the corrected case fatality rate to be 1.38. So we knew already a preprint from this paper for some time, and this was the value that we have been using and are still using for the data that we are doing. So the idea is to have a stable baseline. Unfortunately, as things are going, the information is changing all the time. So if you look at in April 17, there was a big update in the number of deaths that that should have been reported in UN. So we are quite sure that this will impact the baseline that we are using. Still, the other available baselines are report a number that is a little bit higher, around 2. So we are currently considering looking at alternative baselines. We can look at Korean data. This points at around 2.2. And there is also some data from a locality in Germany, in Gangelt, that we will be looking into it. But for now, the graphics I will show you are using the UN baseline. So what can we do? We have a baseline, might have to be adjusted, and then we can pick a given country, and we use data from the European Center for Disease Control. We have the number of deaths, the number of reported cases, so we can calculate how many of those cases had time to have known outcomes, and we can calculate what is the daily corrected case fatality rate. Then what we do is we use a proportion to the baseline to infer the current cases estimate, okay? So if a given country is reporting twice the CCFR of the baseline, this is probably a hint that it is only detecting half of the cases that are actually occurring, okay? And we can also look at the baseline in countries that are already stabilized, that don't have a lot of cases. So there's still caveats on this technique, the CCFR estimate. One big caveat is the baseline quality, as happened in the likely revision of the UN baseline. Also on the policies for reporting of deaths. So some countries, if a patient has been diagnosed with COVID, they will report it as a COVID death. But in some cases, if there are other causes that will kind of justify that death, they might report it under other cases. So that is an issue. The coverage of cases, because we are calculating the CCFR also from the coverage, the calibration of the symptoms to death delay, and the data we get from the ECDC, it has the date of reporting and not the date of symptoms. So there are still lots of issues in the calibration of these kind of estimators. But again, what can we see from these independent estimators? Because the nice thing is that these estimators are independent from the survey, so we can still compare and see how we are. So now we insert these two lines here, and we can see that initially the death times 400 estimate is very close to the CCFR fine-grained estimate, because we are still in exponential growth if you look at the dashed lines. Then as the progress starts being more under control, as the growth rate decreases, we start seeing a diversion of the two lines, and we can see that basically the Dunbar estimate is kind of following quite closely the CCFR estimate. And the weighted estimate, the default one, was closer to the death times 400, but is now approaching the other baseline. But still, these four estimates to the number of cases are more or less in the same region, and they are quite above the reported number of official cases. In Spain, this is even more clear. So we can see, if you look, for instance, at the Dunbar estimate, you can observe that the Dunbar is the number estimate is quite close and follows quite closely the CCFR estimate. So we get the several estimates more or less clustering around the CCFR. So this brings us some confidence that at least for Spain, we are kind of pointing into the correct order of magnitude of values, so more than 1 million cases that were or are symptomatic. And this is quite above the official number of reported cases. So what is the status and potential uses of this technique? So data is being collected since mid-March. By the way, all the data that we are collecting is available, openly available in an open license in GitHub. So people can download and use the raw data. And we also do our estimations and output the data from our estimators. We are still calibrating this instrument as the pandemic and data evolves. And we have surveys that are open for all the globe. So people in any country can answer for their own country. We have open surveys in English for all the world, and we have translations into several languages to make them more localized. We believe that this kind of technique, which is clearly non-orthodox, so there are other approaches that ask directly people about their symptoms. There was a big survey like that in Spain that outputted results recently. But in those cases, you are much more intrusive in what you are asking persons, and you need to deal with personal data. So our big aim here is to be more lightweight, do not get into personal data, and be able to still get a quick assessment of the order of magnitude. So we want to calibrate this technique and see how reliable it can be considered. And we think that this can be particularly interesting for countries with less economic possibilities that still, for instance, in many African countries, there is a very good digital presentation because people still have smartphones, but you might have much less testing available in some countries. So maybe in those circumstances, this kind of instrument can be an interesting complement to the classic techniques. So now I will kind of gear toward the conclusion by looking at the portfolio of the data that we have been collecting. And when this ends, you can all explore on the site. There is a lot of visualizations that can be explored on the site. So this is the results we had from yesterday. We have estimates for these several countries. You can see, for instance, the USA, we don't get a lot of answers there, but you're already estimating above 10 million persons. We have also high results in Spain. We also, in the meantime, we added error bars. So we have the confidence interval of 95% together with the estimates. I can also comment that our team is typically computer science people, networking people. We have many statisticians, but we don't have experts in epidemiology. Okay, so we are basically focusing on these aspects. So we are open to improvements from that community. For France, what can we see? We have the surveys more or less closely tracking the CCFR, which is the blue one. In this case, it is the standard survey that is more closely tracking the CCFR one. An interesting case is in Australia. So we don't have enough answers from Australia, but we are producing the fatality rate based estimates for all the countries that we have data from ECDC. So this allows to see, for instance, here, that Australia is actually reporting the exact same number of cases that existed from the UN calibration. So they are reporting around 1.4 corrected fatality rate. So this is why we got an overlap between the number of reported cases and the CCFR estimated. However, as the UN data numbers are corrected, this will probably mean that Australia actually has less fatalities that occurred in UN, which is also understandable because they never got into a kind of collapse of the system. Getting some instability, just waiting for the connection to get more stable. So in more detail, data from Portugal. So we have the confidence intervals both for the survey and for the CCFR estimates. We didn't put it for the fatalities 400 because this is just a coarse-grained estimate. It's like fidelity should be considered with a grain of salt. As you can see, for instance, around 10 of April, we have a tighter confidence interval in Portugal because at this point there was an article that came up in a local newspaper and we got lots of answers. So as we get more answers, we get more precision on the estimate. Also in Portugal, I will show that you can explore data at a regional level. So we have data for these at least in Portugal, Spain, and I believe in Cyprus. So you can also query at a given region, what is the data for that region? And I got some data from yesterday where I queried for the northern region. So it's Administração Regional Sul Norte. And we can still see that we are kind of tracking the estimated, but before we had values that were closer to the reported values, the officially reported values. So at least here we don't have such a big gap, although we are in exponential scale, in a logarithmic scale. So in Cyprus, so I'm going to the last two examples. So in Cyprus, it was very interesting. We had a team member from Cyprus. We still have it. We're working at that, and he kind of disseminated very early the survey. And this shows that, in particular in Cyprus, we were able to get estimates from the survey even before we could have estimates from the reported number of deaths. So there were no reported deaths at that time, so we could not produce the death-based estimates. And actually in Cyprus, the survey enabled to get like a pulse into the order of magnitude of the infection rate, even before we have estimates that were based on fatalities, which I believe it is an interesting thing. Since the numbers are quite low, the confidence intervals are also large here. And going to the last example in the portfolio, we also ran a very big survey in Ukraine. There was an influencer that shared the link on Instagram. So we got a very representative sample from Ukraine. And as you can see, we have a very strange situation here. Our estimates are quite above what we infer, both from the reported numbers and from the estimates that come from the case fatality rates. So our all interpretation to this is that maybe in Ukraine, there is underreporting of the deaths that are reported as COVID deaths, okay? So we have a very big sample, and in this case, it's kind of a warning that probably here, not all cases of COVID deaths are being properly reported to the CDC. Of course, this needs to be confirmed. So I'm going to finish after this example. Going to unmute everyone. And before that, just say again that both our raw and processing data is openly available. You can check all the names of all the collaborators and check the data. So